Hello and welcome to another episode of Every Possible Angle. Today I'm very excited. We have two special guests here, both from the Norton Thoracic Institute at the St. Joseph's Hospital and Medical Center. We have Dr. Rajat Walia, Chief of the Pulmonary and Critical Care Section and Medical Director of Lung Transplantation, and Dr. Michael Smith, the Chief of Thoracic Surgery. Thank you both for joining.
Thank you for having us.
I'd really like to start with yourselves and learn a little bit more about both of you. Maybe starting with Dr. Walia, how did you start your career in transplantation? What brought you to this field of medicine?
Yeah, so I was an internal medicine resident, and the first decision I had to make was, did I want to specialize? And I ended up being, I knew I wanted to do pulmonary and critical care, enjoyed the physiology, being in the ICU. And at that point, I thought I would just love to work in the ICU all my career. And then as my training evolved, I started seeing more complex cases coming into the ICU, and some patients we couldn't help at all. Mm-hmm. And that led me to start thinking about how to take care of these end-stage patients for which there were very limited treatment options. And I already knew I was going to do a pulmonary critical care fellowship, so I definitely sought out programs where there was exposure to transplant. Mm-hmm. And I still wasn't certain at that point, but after in the middle of my fellowship, I was, I think, quite certain that this is the path I want to choose.
Interesting. Fantastic. And can you tell me about the first lung transplant patient that you cared for?
The first lung transplant patient was probably actually in my residency, not even in my pulmonary fellowship. It was back in the mid to late 90s, and pulmonary hypertension was a disease that had very limited treatment options. Flolan, IV Flolan was just coming around, but many patients at that time needed a lung transplant. And I'm going to really date myself and tell you at that time, a lot of institutions were doing just single lung transplants for pulmonary hypertension, which is a big no-no, taboo these days. So, but that's how, that was my first introduction to lung transplant. I was taking care of a young woman with pulmonary hypertension who'd received a lung transplant. Our institution at that time, where I trained, didn't offer it. She had a transplant at Pittsburgh and was being cared for by our hospital.
Wow, fantastic. And Dr. Smith, how about you? How did you get into lung transplantation?
Yeah, mine was also a bit of a circuitous route. I was a general surgery resident and had the great fortune of training at Barnes Hospital as a general surgery resident. This was shortly, maybe a few years after Dr. Alec Patterson and Joel Cooper had come to Barnes from Toronto General, where they had done the first successful isolated lung transplants in the world. And so that was still a really big deal by the time I got to Barnes Hospital. And, those guys are great mentors, and I think that's what drove a lot of my decision to become a thoracic surgeon, was the idea to be associated with them, as well as the excitement of lung transplant, which even to this day is one of the most exciting operations I do, based on, the anatomy and physiology from the donor operation to the recipient operation, and the immediate impact that you have on the patients in terms of their quality of life and longevity. It's just a pretty magical thing that we do in medicine.
It's something I feel I commonly hear is just the transformative effect of transplantation, that the sort of immediate impact of a patient who has end-stage organ failure and then has been transformed in terms of their lung function just immediately after the procedure. It's really an incredible experience. Can I ask you also, sort of, Dr. Smith, you were talking about the impact of mentors in your life to move you towards this field. I think that's also really critical in medicine is finding those mentors that move you along your career. And then I think you both now as chiefs, you probably also have that effect now, or a role for younger physicians. How do you see that role in medicine, and how does that impacted your career?
Well, yeah, as I mentioned, it had a huge impact on me, not only in terms of the selection of a particular subspecialty, but also receiving the support and encouragement that I could do it. And now, all these years later, I'm much older now, and the roles have reversed. Dr. Walia and I both have teaching appointments, and so we do work with both residents and medical students. Mm-hmm. And the roles have been reversed now, where we are the mentors, and we support the younger generation of physicians and surgeons coming about. And I think it's very important in academic medicine. I mean, that's how we leave our legacy, right? We can only take care of so many patients in our lifetimes, but in some ways our impact is indefinite because we teach others who go on to teach others, who go on to teach others, and it goes on. So that's the neat thing about academic medicine, really.
Similar for you?
So I would just like to add to that is, in residency and fellowship, where we think of classic academic medicine where training and teaching occurs, is very structured. Right. There's didactics, there's defined pathways, but I think a lot of growing up happens when you take your first job. Right. And I think it's really important to be available to your junior faculty, younger attendings, because that can be a place people can easily get lost in because people are thrown into the real world and expected to just do the job. And I think it takes a couple of years of being an attending and adjusting to the role. So both Dr. Smith and I are fortunate that, we have a great team of both pulmonologists and thoracic surgeons at the Norton. And we've had the privilege of, bringing many of the younger faculty along. So to me, when they just come out of fellowship sometimes, that's the real first couple of years are the real key, how they're going to establish themselves as independent practicing physicians.
And to that sort of transition from sort of theoretical to the practice of medicine, in that transition once you get into the real world, I think one of the unique things, not only I think every field of medicine, there's a lot of challenge when you make that, and there's the responsibility to make the right call and deal with those decisions. But transplant in particular has, I feel, a large element of teamwork and leadership, and because it's so cross-functional and interdisciplinary in terms of taking care of these patients, and that I think that I would imagine a lot of that comes after fellowship training, after sort of the technical and getting onto the real world. Is that true, or how do you see that in your institution?
Yeah, very much so. I mean, and as a transplant fellow, you could be either whether you're on the surgical side or pulmonology side, you have a team you answer to. They work cross-functionally, as you say, across different disciplines, not just medical specialties, but even in medicine between nursing, physicians, pharmacy, hospital leadership, C-suite, different hospital units, ICUs, endoscopy, ORs. That real exposure comes as a young attending when you're thrown into there, and really understanding the journey, not just of the transplant patient, but also the transplant process takes significant amount of time and guidance to get through and understand. And each institution is set up so differently, so that doesn't make it super easy. But I think at Norton, we are very fortunate that we have a great team, and we are set up in an institute model where thoracic surgery and pulmonology work hand in hand. We are one department, so sometimes in traditional academic institutions, there can be silos between Department of Medicine, Department of Surgery, that can create some of this cross-functionality, make this a little more challenging. But we are very fortunate. We are set up as an institute where the surgeons and pulmonologists work hand in hand. Our team's really cohesive and works well together. Same for nursing. Again, in the institute model allows us to have the nursing and pharmacy and all the disciplines that help take care of the transplant patient under one roof.
Absolutely. And even to some degree, you have to even go beyond that one roof to work with OPOs across the organ procurement organizations across the country and make sure that this whole event of transplantation is orchestrated seamlessly. I mean, Dr. Smith, your team must travel quite a bit. They have to do a lot of recovery, work with a lot of different hospitals and institutions. How is building that network and working with so many different individuals? Normally, when you do surgery, you work within your hospital walls and don't have in one sort of hospital system, one surgical system. Can you tell us a little bit about that?
Yeah, well, the nature of transplant obviously requires us as surgeons to be able to operate in other facilities for the procurement events. And that's been the case from the very beginning. I think the things that have changed more recently with changes in technology, changes in allocation platforms, et cetera, is that now we have to be a lot more savvy about establishing relationships. Early on, it was just OPOs or organ procurement organizations, and now it's actually other institutions and other surgeons because we are now slowly migrating toward a model where we're not really doing our own procurement per se. The way the allocation scoring system has changed is such that many of our offers are coming from great distances, and many of these are DCD donors or donation after cardiac death. Maybe we can get into that a little bit more detail later, but these are donors that may actually not become actual donors, if you will, and there's a great expense associated with traveling these great distances and coming back without an actual set of lungs to transplant. So we are now establishing closer relationships with other institutions and other surgeons to help us with local procurement services. And that's not just lung, that's that's across the board. And so those are some of the things that have changed over the years, is that we are having to network and be less just self-reliant. We actually have to have partners across the country to do what we do.
Absolutely. And maybe let's get into sort of some of the evolving landscape of transplantation. So St. Joe's, you're a large lung transplant institution, over 100 transplants a year on average. And you're, I think in 2019, you did almost 120 transplants in Arizona, where obviously it's more geographically isolated from other populations to get access to organs. And over the last few years, can you tell me a little bit about this program and how this really large program is continuing to evolve in the changing face of some of these allocation changes, and even things like COVID hit the lung transplant community quite hard. Dr. Walia, you want to start there?
Oh, wow, that's a lot to unpack here. But, this is the third iteration of the lung allocation system in my career, from time-based to LAS, now to CAS. And the lung allocation score also, evolved during its lifespan. And now we went to this continuous allocation score model. And clearly what we have seen is we're transplanting more, rates are going up, waitlist mortality is going down, but many different kind of challenges on the systems, on institutions, and we will probably talk a little bit more about that. But getting back to our journey over the last 4 or 5 years, 2019 was 119 transplants at our institution. And then come 2020, we got hit by not just COVID, we had a lot of things happen. That 2020 to 2022 was a little bit of a kind of a different phase in our program's life. We got new C-suite professionals all in there. Our C-suite was brand new in 2020, or it became brand new over 2020, 2021. We also had some surgical turnover on the team between 21, 22. So, what we're trying to discuss is the programs, even that are established, have been there for a while. they will see some changes during their lifespan. And we have to be nimble, and we have to be agile and be able to adapt to the changes. Like adapting to CS was a big change. But, one of the other partners, which as Dr. Smith was alluding to earlier, is external organizations like OPOs, procurement surgeons, is really the C-suite. Lung transplant is a expensive endeavor. It's life-saving, but it takes a lot of resources. So unless you have buy-in from the hospital executive leadership, it's really not going to succeed. You need a lot of investment, both in resources, personnel, and a desire to be a center that provides this life-saving procedure. And so, there are many aspects that change between 2020 and 22. And one of the things I'll talk about is the executive leadership. As that changes, the transplant teams have to be their job becomes sort of rebuilding, re-educating. Not every C-suite may have the same vision or the same breadth of knowledge. So we have to be the experts and bring them along, and usually that takes a little bit of time. One of the other things, teams sometimes can, for various reasons, experience turnover, whether it's in nursing staff, medical staff, surgical staff, and how to adapt and change. Mm-hmm. And that's where getting into some of the external partnerships, being less self-reliant, comes in.
Absolutely. So a number of things there. In terms of that part, I think that awareness, and that's, for physicians who are trained on the care of patients and focus their career on the care of patients, to be able to speak the language of a C-suite and help them along the journey understand why the Transplant Institute is so critical to this organization. Because it's clear that your team has built a very mission-driven team within the Institute. That is not necessarily a skill set of speaking to executive boards that you necessarily in your academic courses. I would imagine you go over a whole lot. How when you make that evolution to having to be the representative of the Transplant Institute, say to executive teams, what does that look like, and was that a new challenge when you first entered some of those conversations?
Yeah, so I'll let Dr. Smith also add to that, but we were very fortunate when we started. It was a brand new, the hospital where we are at did not perform any sort of solid organ or any transplants. So lung transplant was the first solid organ transplant they decided to embark their transplant journey with. At that time, the president of the hospital, the CEO, super committed. This was their baby. And we were very fortunate. We had a very, very stable administration for over a decade, almost 12 plus years. And so we had constant seat at the table. This was a program we built together. Yeah. So being partners with them was something we were used to. It was just new personnel, new people from different institutions. So we had to just, we had gotten comfortable in having a stable administration for so long. We just had to now get in there and do it all over again.
Yeah. And one of the other aspects you touched on that I think is really important and not entirely unique, but definitely accentuated in transplant compared to other disciplines is the impacts of staff turnover and the intensity of the field. Transplant, you don't get to dictate when transplants happen. Transplants organ availability can happen in the middle of the night, can happen all over the time, which is it can be quite exhausting. There are talks and papers about the effects of burnout and the how that affects teams, and I would imagine that sort of thing can really lead to team members either burning out or leaving, and that can be quite disruptive to a program. I mean, Dr. Smith, particularly on the surgical side, I imagine the demands of transplant can be quite intense.
Yeah, I like to say that transplant is a young man's sport, but I'm no longer a young man. No, I think it goes across the medical and surgical specialties. We have a program where the surgeons are very fortunate, and I think the program is too, that our pulmonologist partners take the donor calls. And so they do a fantastic job. And I really do think that that is one of the main pillars of our success and volume, is that it's not a resident or nurse practitioner or some other sort of less experienced party that's taking those initial donor calls. So we end up taking donors that a lot of other institutions may take a pass on because we have a more experienced person sort of receiving that first call. So there's a lot of work that's done on the part of our pulmonologists to take donors that other institutions may have taken a pass on, and they actually work with the OPOs to make that a good donor, good viable donor for one of our recipient candidates. That process can take hours and hours and hours, even before the surgeon gets the call that we have a reasonable donor. And then once we have a reasonable donor, then the surgeon kind of takes over and works with our coordinator staff to work on the timing of the donor operation as well as the recipient operation, et cetera. And then obviously there's a lot of physical work that happens in terms of, when we're doing our own procurement, to go out and fly out perhaps to the donor site and then fly back and then do the implantation. We do not have, as typical academic centers do, a cardiothoracic residency or fellowship program many years. Sometimes we have a non-accredited fellow, but for the most part, it is the attending surgeons who are doing all of this work. And so, as you can imagine, that is pretty onerous in terms of the time alone that's spent on one particular transplant can be upwards of more than 12 hours of work for one actual transplant. And that's just on the surgeon's part. That's not even including the pulmonologist. And then to your point, much of this happens in off hours, non-banker's hours, as I like to say. It's usually nights and weekends. And that's impactful for, the level and stamina of the provider themselves. But then in many ways, it also can impact, I think, and I don't know that there's a way to measure this very well. People don't talk about it, but it can also affect other parts of your practice, because as general thoracic surgeons, not only are we up at night doing the transplants, but we're also in there the next morning at 7:30 for that lung cancer operation, take care of that patient, or esophageal cancer, et cetera. So it's hard to imagine that it doesn't impact your sharpness, if you will, for that next set of patients that you're taking care of during the banker's hours at, those elective cases. So the impact of the sort of unpredictability, the labor intenseness of transplant is it goes across your practice. It's just not limited to the transplant program itself.
Now, your program in particular has embraced what we're starting to see in the field as an evolving trend of extension of ischemic times for a variety of purposes of either daytime procedures or also logistic purposes. Historically, transplant, the timing of when this donor procedure happens somewhere in the country with multiple organs, all depending on that one procedure, where it was intrinsically linked to the timing of the start of the recipient procedure. But recently in lung, it seems to be this evolution where that has started to have a little bit of elasticity, a little bit of flexibility between those two timings. And we've heard of programs sort of implementing this in a variety of ways. Sometimes taking multiple donors where they historically could only have accepted one because they would have arrived at the same time, and using extra time. Can you tell us about a little bit in terms of this evolving trend of being able to have more time with advanced technologies and approaches to transplantation preservation?
Yeah, no, this has been a real game changer. So as you alluded to, there's at least a couple of reasons that we may choose to not pursue the actual recipient operation so closely linked to that donor operation, which historically determined everything else. When that cross clamp time was, the clock starts ticking, if you will. And so now we've been able to extend that with various technologies. I'd say EVLP is one, and probably the most recent and very impressive one is with companies like Paragonix, where we're able to do sort of over freezing temperatures for preservation. And ironically, that gives us much more leeway and a very good preservation with extended times. And it allows us to, like you said, we can have simultaneous donors that we're working with for two different recipients. And rather than having to have two separate teams, that means a separate OR, separate nursing staff, separate anesthesia, separate surgeons, we can sort of more electively sort of have those cases go back to back. And it's a huge advantage in terms of the resources that are need to take care of those patients. The other setting is that simply you would rather than keep your team up all night doing these operations, do it during sort of normal working hours where you have a fresh team, which kind of talked about the advantages that has for both the team and the surgeons and perhaps the patient. And then the other setting that I should mention is that occasionally we may have a situation where we need a cross match that takes time to come back, or there's some other logistics issues on the recipient candidate end that need to be sorted out before we can proceed. It just really opens up, gives us much more flexibility, if you will, in terms of how we proceed with these transplants logistically, and it's been a huge benefit.
As the last one was really interesting to me. So the cross match patients where you're waiting for a cross match. In this case, historically, if you didn't have that in time, these are organs that potentially, though the donor or donor family wanted to help a patient, may have gone to waste because they couldn't have gotten that testing done in time. And in this case, you're able to extend the time and actually get that done. Is that the right understanding?
That's exactly right. So. And you may have a couple of patients on the list that this donor set of lungs may be a match for, but if there's a cross match issue, you can pass up your number one priority and go to the number two. And historically, if you didn't have that sort of flexibility in time, you would simply have to take a pass on those donor lungs, and either they would be transplanted elsewhere, which is a good thing, or there may not be another institution or candidate recipient elsewhere in line that could take those lungs, and so they would not be transplanted, which is unfortunate.
Over the last few years, we've just seen a lot of not just the complexity of donor offers, more DCD offers, but one of the things we're seeing is sometimes the hard-line donor OR withdrawal times that we are facing with from the OPOs, if they're in a big center, trauma center, where OR time is, precious, limited. They have to go to OR a certain time, and we're running into family time constraints. And sometimes that brings up a situation where this is your window to retrieve the lungs, and you may not have all the information you need. Just like, as you mentioned, cross-match, we had a situation where some of the serologies were not back yet. The OPO wanted us to come and retrieve the lungs, and they were going to, they had to go to OR. They're willing to wait for us to get the serology results to make the final call, but we had to go to the OR. So having access to a technology where we can sort of stage this in a predictable manner really, really helped to salvage those lungs, and we were able to transplant a sick young woman and have an excellent result. And I think Dr. Smith maybe touched upon this, but there's a couple of other things that this has allowed our program to do. And one of them is the OR staff, pulling them at night may have some financial implications for the institutions, being on call and being able to do these daytime transplants. The other thing, probably Dr. Smith can speak to this better, is I think knowing when the transplant is going to happen may have an impact on their elective cases, right? They can stage this, they know when it's going to happen. And I think it's less disruptive to their routine and practice, or knowing who can do the transplant. I think till a couple of years ago, it was just the transplant is happening now, and the next day would have all to be reorganized, which would affect patient care or flow. So I think there's a lot of things, these evolving technologies are changing the landscape of not just transplant, but how the workflow happens at institutions.
Not just the transplant procedures itself, but all of the ripple effects of a sudden transplant dropping in and disrupting everything else. If you have more time, it's easier to manage and restaff and shift those programs around.
Yeah, probably. At least you can predictable, and you can pull in other team members, and often during the day, you may have more surgeons available. There are more complex cases that can be done, with increased level of safety and reassurance. I think there's a lot of benefit, not just having fresh teams and, as Dr. Smith mentioned, sharper teams in the morning who have had appropriate rest. I think every industry, we see a classic example, airline industry. Every industry that has high-performing status has this sort of a recognition of sleep deprivation and burnout. And I think I'm glad finally in transplant we are getting there, right? It's a job that never ends. It never ends from donor call, OR, ICU. But I think this may be a boon in so many different ways, having access to this kind of technology.
I mean that's it's so true. We see timeout limits on all sorts of spaces, but where we don't classically see that in medicine. And so seeing that being able to be more possible, more predictable. You were also telling me, I think that not too long ago when we met a couple months ago at AATS about a case where in a few days' time your team was able to do far more transplants than you would have in the past. I think it was a 5-day span, and it also seems by being able to adjust the times and have them at a regular basis rather than some of the organs all showing up at once, or being able to or in the middle of the night and having the teams exhausted, you're able to serve more patients, do more transplants with the resources you had. You extend those resources to grow the program. Is that a fair understanding of that?
Yeah, that's true. I think that was back in May when we did 17 transplants in the month of May 2024. And 9 of these transplants, I think, happened over a 5-day span. And typically, we have a surgical team on as 2 surgeons, as Dr. Smith mentioned earlier, they're attending surgeons, right? There's a main transplant surgeon, and there's always a backup surgeon. And we were able to stage these transplants, and there was another team because we could predict when these transplants are going to happen, and we were heading into the weekend. Another team of surgeons came in to help with the couple of cases before the weekend, and then we didn't have to pull in extra people in because we could stage the transplant, and the same team continued to perform the 9 transplants over a 5-day period. So it wouldn't have been possible like a couple of years ago when we didn't have access to where we could sort of time shift these procedures.
That's wild. That's incredible. I think just touching on some of the changes and shift in the era to the post-CAS era, the allocation changes that have happened, and Dr. Smith, you touched on this as well as you, Dr. Walia, that these allocations and changes have evolved over time. They're redesigned and reanalyzed to improve access to transplant, distribution of organs all the time. And oftentimes in the last 2, a lot of the focus has been about both equity of access, prioritizing the patients who are sickest on the wait list, and there's a lot of evidence showing that they have improved those metrics by breaking down some of the regional barriers and letting organs come from further away. However, with that is also coming burdens of, when you're trying to recover organs from long distances away, particularly more complex donors that may be high risk, as both of you said. It's unclear if this organ will be usable. These present new challenges, new resource challenges. Can you tell us a little bit about, Dr. Smith? You were starting to touch on that earlier about that sort of evolving landscape and new approaches you're taking to be able to handle the breadth of geography now you're recovering lungs from.
Yeah, as I mentioned earlier, to expound on that a little bit, we're really required to rely on and trust other experts in the field. Historically, programs were pretty reluctant to allow someone else to procure organs for them just because of a matter of trust or wanting to really be on top of and responsible for all aspects of the care of your patient. But it is really, this new allocation system and the distances and the sort of not necessarily lower quality, but unpredictable quality of the organs that were being offered now has really required us to relax on that front and be more cooperative with each other in terms of allowing other people to help us with that work because they're local. Mm-hmm. And I really think that, this will play a larger and larger part of the future of transplantation in general. I think that, other organ systems have been doing this successfully for much longer. And I think that lung is just sort of a little bit, later in adapting this protocol, but I think it will become the future of transplant that you will likely see more teams procuring for each other than teams procuring for themselves. I think it just makes sense in terms of the resource allocation alone. It just makes sense to do it that way. And so to do that, you really need to network. There are multiple ways to engage other experts that are local, either through companies like yourselves or others. There are some standalone procurement surgeon companies. Mm-hmm. And then, we all have personal contacts in certain regions as well that we can sort of enlist to help us with these procurements. And we do get calls from our partners across the country as well to help them when they have an organ here is local for us. So and I think it's a good thing. It requires us to all work together for the same cause. Obviously, we have a special priority and interest in our own patients, but for the general patient population out there, we want to do the right thing as well. So I think it's really been good for the specialty as a whole.
Yes, I'd agree. I think it's interesting how it's becoming even more interconnected and more of a team sport as with these new allocation changes, longer distances. And I can say I know from our teams, particularly the types of case that you were talking about, the donation after circulatory death. Those cases in particular, you often don't know if the patient will proceed to be able to be a donor, and so there's a question. And if you're deploying a team local from your institution out on a private jet across the country, they're there for this long period of time and returning back. That's quite can be quite burdensome. I know from our team, we tend to get our surgeons get deployed to cases where there's actually a higher likelihood that this might happen. But if they're being deployed locally, that's less of a resource burden. They oftentimes 40 or 50% of the time can, and that's good for the institution because then their people aren't across the country for 12, 16 hours. And so I think that's an interesting space for us because we see a lot of these cases where the main reason they're being deployed is because it's uncertain whether or not this will be a viable set of lungs for donation. And I'm curious towards your team's rubric for when to use the different resources that are available to you. How do you approach that? How do you choose what, is it worth it to send a local team? Is it or send a team from your institution or rely on a local team? Does it depend on the type of donor or is it just around distance? How do you approach that?
Yeah, I think it's a combination of distance, donor quality, and for DCD likelihood of expiration. And that donor becoming an actual donor. I would say the majority of the local donors that are either here in the state or here in the Phoenix area, we will just go and procure ourselves, whether it's a brain dead donor or a DCD. The amount of resources and time that's required for that is quite minimal. But let's say it's a DCD with uncertain quality that's several states away, then we're more likely to employ a local team if we can, or someone else on the ground there. And that saves us the expense and time of that particularly not problematic, but it's not favorable to have what we call a dry run, where you've expended all this time and resource to go for these organs that don't come to fruition. So those are sort of the things that we take into consideration. I would say that, as in everything else, cost is a big deal, because, those are expenses that typically don't get directly reimbursed by the transplant center. For those dry runs. The institution doesn't get compensated typically unless a transplant occurs. That's just the way our healthcare system is run. There is some allocation based upon like a Medicare cost report, et cetera, but it's very complicated. It's not a direct one-for-one reimbursement for those dry runs. It's usually to the tune of what your Medicare population is, et cetera. It's very complicated that way. So, yes, we are, using those sorts of algorithms to make those determinations. And I hope we'll get into it. But one of the exciting things that we've been able to do that's really been exciting in terms of cost and time allocation is commercial flights that we've been able to do with your company that allows us to have a local procurement surgeon take care of the procurement process, and then the lungs come back to us on a commercial flight. That's the level of comfort that we've had in terms of our ability to time shift in these prolonged preservation times, and that's been very exciting. And we are hopeful to see more of this in the future. Honestly.
Can you tell me more about that? Now, how specifically? Because your program has really started a brand new wave here with this approach, and our team has been collaborating with you on it. But I'm really curious in that, without a doubt, with the allocation change, historically, transplant centers relied on private aircraft for all of these private charter jets in order to get the organs from site of donation to site of transplantation as fast as possible. And so obviously private charter is not inexpensive, particularly even on dry runs. So if for your team, how has this gone, and how has that evolved for you, and how do you think this could potentially impact in the future the St. Joe's program?
So I think I just want to back up a little bit how this has evolved. So I want to clarify something I said earlier. Transplant surgeons are a rare commodity, right? And so when I say turnover, just even one surgeon relocating for family reasons can be really disruptive to the program, because then the senior surgeons who have other practices can be pulled in different directions. So sometimes and even big academic centers, institution transplant may have only 2 or 3 transplant surgeons. So even the term turnover could be like misleading. It's not really we're talking mass exodus or something, but just even relocation of one person could be real disruptive. And because we were so used to doing transplants with 2 attending surgeons, even just loss or relocation of 1 or 2 surgeons can have huge influence and impact. So we needed to evolve into something that allowed us, our surgical team, to be preserved, not burn out, plus all the logistical things we talked about. And Dr. Smith touched upon that. We needed something that was palatable to our C-suite, from a finance standpoint. Plus, we were at a time as a busy program, we needed to be able to be nimble, and we needed something that was commercially available. We couldn't just this was not participating in a study right now. So that allowed us, that actually forced our hand into start experimenting, not experimenting, but, start utilizing some of these technologies that were available. And that led us to start using LungGuard as first. And what we noticed was happening around the country with CS, people were traveling further. We noticed we're traveling further, but as we started using LungGuard and we started having comfort with time shifting. Some of the cases before 23, our ischemic times definitely were like in the 6 to 8 hour range on the higher side. But now, routinely we have much higher ischemic times without any untoward outcomes, no increased signal in PGD or post-op stay. So we've gotten more and more comfortable. I do need to talk about this evolution because getting the comfort with that prolonged ischemic times, if you will, and not seeing any untoward complications or untoward signals, probably thought we could probably, where does this ischemic time happen? Does it matter? If the box comes and sits in our hospital overnight, we're not going to do the operation till the morning, or is it more reasonable to, figure out if there's a more efficient, it maybe stays at the donor hospital an extra hour if this can get on a commercial flight instead of a charter flight. And really have to give kudos to you guys for, allowing us to have that accessibility through NORA. And we were able to get our first set of lungs on a commercial flight. It was a Paragonix, the first Paragonix experience on a commercial flight, and really start thinking outside the box. Like, I think we need to, where does this, if we are going to prolong the ischemic time, does it really matter where it happens? And there was a commercial flight, there was a backup commercial flight, and you can also have a charter flight available. And my understanding is there's different levels of standbys for charter flight that institution could end up paying. And I think it costs significantly less, but there might be huge environmental impact of, the charter flights and the fuel consumption. So I'd like to hear what Dr. Smith has to say about this. But, I just wanted to talk a little bit about the evolution, how it came to accepting prolonged ischemic times that allowed us to start thinking about, can we change the paradigm here? And, charter flights have been the gold standard, but it's time for a change.
Dr. Smith?
Yeah, I mean, I think it's once again, I mean, these sort of advancements have been just real game changers, and it all hinges on our comfort level with that prolonged ischemic time. And, obviously we don't want to push the envelope, more than we feel comfortable with, but we've already doubled the expected ischemic times that we were using on, standard preservation with ice. And so it's unclear, what the upper limit will be. I'm sure there will be new advancements that may come along to continue to even push that further along. But it really is allowing us lots more flexibility in terms of the logistics of doing these cases, in terms of the time, the types of resources we're using, and then transportation is just one of those resources. It's really been exciting to be a part of, and we're glad that we could kind of help lead the charge on this, if you will. Pretty excited and proud of that.
Even with the allocation policy, there's a scoring in the continuous allocation policy for placement efficiency, basically based on distance. And could you imagine, right now there's a certain weighting towards that that affects what offers you get from further away. Could that be adjusted if the resources and the model starts to change to be more of a distributed network and efficient delivery through things like this commercial aircraft approach?
I think we are certainly seeing that. I think transplant has become more accessible to patients. Like some of the patients prior to CS, like patients who are highly sensitized with high anti-HLA antibodies, or patients of shorter stature typically had longer wait times.
Mm-hmm.
And, longer wait times are not necessarily good. Sometimes that may mean waitlist mortality. But the CS definitely is doing what it's supposed to do, of increasing volume, transplant rates, decreasing waitlist mortality. And we're seeing that as a consequence of patients are getting offers from much further away. But it's coming at a cost to transplant centers and institutions. As we discussed earlier, distance, geography, complexity of donors. So while we have more accessibility, we have to figure out how we're going to grapple with this distance. Mm-hmm. And I think having access to such technologies has allowed it to be possible. I cannot imagine we would be sending our teams to fly, more than 1,000 miles, 1,500, 2,000 miles for a DCD, which we were not sure was actually going to happen or not. But now this external partnerships has definitely made that possible. I just hope this also translates into, the rest of the, we talked about different partners we have to work with, with insurance companies and payers, coming to terms with the changing landscape of transplant. It's definitely happening. I don't think anybody's going backwards. I think this is the setting the stage for a new norm. Now, how this will evolve, we will see over time. There's multiple models out there. Could we even have a day where you're using different combination of technologies paired up together? But institutionals will need support from, the managed care and payer industries, from Medicare, Medicaid services, to be able to keep up with this rising cost of transplant that's coming with CAS.
Absolutely. I'm also curious just on that sort of resourcing around CAS. Certainly it's fantastic to be getting offers from around the country and being able to entertain those and actually take advantage of those. But yes, there's the resources around deployment, but I would imagine there's also a larger volume of offers that have to be triaged. And Dr. Smith was saying that the pulmonology team takes initial call. Has CAS affected sort of the volume that you're viewing in terms of call? Now you're taking now that you're looking at offers from across the country, or has it just shifted the mix?
Oh no, definitely it's gone up. In fact, we had started seeing a deluge of offers coming in just even before CS. I think CMS had changed the metrics for the OPOs, how offers they're going to be weighted for their offer extensions. So we were getting inundated with offers, but it has definitely exploded after CS, and the changes within the UNO's DonorNet system. Just to give you an example of how many calls you may get for one potential offer. It starts as a phone call or an email that you get. You have to respond to it in a certain time frame. Then you get a notification, typically by a phone call again, when that donor your center is backup for, and then you get another phone call that you're primary, and then and that's just 3 calls from within the UNET system. That's excluding all the calls back and forth that happen between the OPO and all the text messaging that may be going on, or whatever communication tool you have. The number of phone calls and messaging is just onerous, burdensome. It's a lot just for one, and it doesn't stop. Even though we have being able to time shift the transplant operation during the day, the business of donor call doesn't stop. This keeps coming at all hours, all time. If the internet is alive, you're getting donor calls. Definitely the volume has gone up, the time has gone up, and this is another burden on transplant centers is to have sort of donor call teams or organ placement specialists, different names at different institutions. At our institution, it's the pulmonologist who bear the brunt of this call.
Okay, and which is a little bit of a unique model. but it sounds like it's been quite effective for you to be able to tease out offers that maybe others decline. Is that fair?
Yes, I think because we are frontline and reviewing the donor. Sometimes that helps, even though it's I'm not sure how sustainable that's going to be long term without having a buffer between the pulmonologist and donor call system. But what it allows us to do is review a lot of the information with a lens and maybe pick up on some what others would consider marginal extended criteria donors, or even consider high-risk donors. For example, there are often right heart cath data or pulmonary artery pressures in a donor information that even experienced physicians may have trouble sometimes interpreting, and just having a physician level look at that kind of data and make those calls is very helpful.
I can imagine, and I'd also imagine that the acceptance criteria, what is an acceptable donor, isn't necessarily a static thing, in that for one patient, one recipient, or a different recipient, or even the same recipient 1 week versus 2 or 3 weeks later, if their condition has changed dramatically, there's a two-sided equation here, and just because you might accept one donor one day, it might not be the same. That might not be an acceptable donor for a different patient. How much does that, in terms of donor call, that knowledge of the exact state of that recipient at that moment, play into the acceptance of a specific donor?
Huge. I think we look at donors always with the recipient or recipients in mind. And our approach really at our center, because the pulmonologists are taking call, is that every donor is a potential donor. Like there might be findings on X-ray, CT that may want you to say, oh, this is not a good donor. But our question always, philosophy, is why not? Why can't? Can this be turned around? And we often find just having that conversation with the OPO allows us sometimes a donor that maybe was declined 2 days ago and they've been able to diurease or make some vent changes, and then they call. We get a call back to our center. Hey, we are just approaching back some centers that were in the mix, and would you reconsider this donor? So that's the donor clinical condition that can evolve, but also the donor in the context of recipients. As you mentioned, a recipient getting sicker may force us to look at a broader category of donors. Yes, it's a dynamic. We have traditional donor criteria, but really we have to be kind of dynamic and fluid with that.
It's hard because you have to have someone, and really the pulmonologist, I would imagine, are sort of at the central there, that has that awareness on both sides of what's evolving with the donor and what's evolving with the recipient to make that call.
Yeah, I do think that's not just unique, but also a strength of our program,
right?
How we're able to do that and support and provide that service. But it also keeps our pulmonologists energized, a buzz, even though we complain and whine when we are on call. But that's the part of the job that keeps us most motivated. And what it really allows us to do is really work hand in hand with our surgeons. Of course, every donor offer is reviewed with them, but they are really looking to us to be the partners in making the right decision, that level of trust, the camaraderie, the cohesiveness. It's real key. And we really feel fortunate that our surgical team and our patients, put so much trust in us, and that we'll make the best decision.
That's fantastic. And I think it's really interesting because this is an evolving landscape, and I think lots of teams are grappling with this about whether filters or outsource groups or pulmonology or surgical, how to best tackle this problem of the growing volume of offers.
Yeah, so even though I mentioned that, we probably with the volume may need a buffer with the pulmonologist, but we strongly feel that our pulmonologists will be the forefront of donor call, even though we may have some either clinical or non-clinical or clerical help in managing the administrative side of UNET, like putting in the checkbox of a provisional yes, or just being sort of the communicators with the OPO, but we still will continue to manage the donors. We feel just knowing what's happening with the ventilator, the oxygenation, the antibiotics, looking at the infectious disease serologies, looking at the heart cath data, like there's so much information that's complex and needs analysis. Really, no donor should be turned down without, I think, a very, very, very thorough and thoughtful kind of reasoning.
Could you tell me a little bit about sort of in terms of where St. Joe's is going and where you see potential, the future for either transplant or lung transplant, or particularly the St. Joe's program? What's next, and where do you see as the next big frontiers for St. Joe's?
Yeah. I see us continuing to grow in terms of our volumes and our ability to take care of more patients both in this region and outside the region. Our hospital has joined a much larger organization in terms of the corporate level, Common Spirit, and I would really like to see more of a networking in terms of using that relationship to get more patients into our system. We have a pretty good experience with transplanting patients from all over the country at this point. And we also have a pretty decent international experience as well. And I'd like to see us continuing to expand upon that to serve more patients within the region, in the country, and international if possible. And I think that that's all within our grasp, and it's what we're continually working toward.
We are the only transplant center between California and Texas. It's the Wild West sort of, but our surrounding states, both New Mexico and Nevada, have not had a lung transplant center, and don't see in a foreseeable future them having one. So we are used to serving a wide geography. And I think we're going to continue on that mission to serve all the people in our region and nation. And we get referrals from all over the nation, sometimes patients that are turned down at other centers. We're part of a national organization now, Common Spirit. We have another hospital, the Baylor St. Luke's CHI Hospital in Houston, is part of the same parent company as we are at St. Joe's in Phoenix. So one day maybe I'd like to see sharing of resources, and how we can all, I think the CES is making us come there, of us all collaborating, and not just within our parent company, but also with external organizations. We'd like I think, and a lot of programs have seen growth lately. So our mission remains the same, to continue to serve the patients that come to us, and maybe even help patients that are turned down at other centers.
Before we go, I just asked, are there any particular events you'd like to highlight that are coming up that are particularly passionate for you?
Yes, I would definitely like to invite all of you, or all the audience that are listening and not listening, to come to the Advanced Lung Disease and Lung Transplant Symposium hosted by the Norton Thoracic Institute. It's going to be in beautiful, hopefully sunny, Scottsdale, Arizona. It's January 17th through 19th, 2025. It is the MLK weekend, long weekend holiday. So we have an expert panel of speakers. The first day usually focuses on advancement in lung disease, specifically diseases, end-stage lung diseases that definitely don't have a cure and transplant may be needed, like pulmonary fibrosis, pulmonary hypertension, and then slowly starts evolving into lung transplantation. We have a panel of both national and international speakers coming. It'll be a fantastic conference, great event, good way to network with colleagues, low-key, and network, socialize, and learn a lot. So I invite you all to come to Arizona in January 2025.
Excellent. And I've heard from physicians, surgeons, and pulmonologists across the country of their interest and their plans to come. So should be a great event. And I think to what both you and Dr. Smith have been speaking about this hour, the importance of networking and trust, and not just within the institution, but as a community is only getting more and more important.
Yeah, definitely.
Yeah.
Trust, collaboration between physicians, surgeons, transplant centers, OPOs, and now even industry.
Absolutely.
And now we just need to get the insurance companies on board.
It's the next step, the new frontier. All right. Well, thank you so much for joining us, both of you. We truly do appreciate it, you both making the time. And we look forward to having you on our next episode of Every Possible Angle.